So here we are going to look at cardiovascular physiology, and this is a great a picture that is there, which I've taken from your books. And if you look at it, it describes the cardiac cycle, but instead of describing both um, sides at the same time, it goes in a stepwise fashion. So take a look at it. It shows you how blood enters the right atrium through the vena cava, and then the right atrium pushes it into the right ventricle where the AV valves open. The right ventricle then passes the blood into the pulmonary trunk, and the semilunar valve opens. This then goes into the lungs where it's oxygenated. The oxygenated blood is then brought into the left atrium by means of pulmonary veins, from the left atrium through the mitral valve into the left ventricle, from the left ventricle into the aorta, out to the body, and then to the tissues, where then the capillaries form veins and blood returns to the heart. So make sure you look at this image carefully. Now here let's look at some terms we use in the cardiac cycle. The first one is called systole or systole, and the next one is diastole or diastole, and this is to do with ventricular action. So systole is ventricular contraction and diastole is ventricular relaxation. And in this, the ventricular relaxation portion, which is the diastole, this is of a variable length. Systole, on the other hand, is more constant. And here, if you think about it, there's a reason for it. There's a very good reason for this. A systole, when the heart contracts, it has to do some activity. So it has to use up energy. And there is only so long that it can contract, because otherwise, if the contraction is very, very prolonged, it'll need to use a lot more energy, and plus it'll get tired or fatigued. Diastole, on the other hand, is one where the ventricle relaxes. So you're able to relax for as long as you want. And in the heart, this makes it useful because when the ventricle is relaxing, it fills with blood. So the more blood there is in the ventricles, which we'll see later is something known as end diastolic volume, the better the ventricle will, the more the ventricle will be able to push out with each beat of the heart. So that's why diastole is of a variable length. So now let's look at the events. So here we are looking at, first we'll start with diastole. So the ventricle is relaxing, and at this time the blood is returning from the body. It returns to the right atrium. I mean, this happens on the left side also, but I'm just going to use the right atrium as an example. So here the blood returns and the atria fill with blood. And remember, the atria are present superior to the ventricles. So as they are filling with blood, it's easy for blood to pour from the atria into the ventricle. So that's why these atria are present superiorly. So as the atria fill with blood, the pressure inside the atrium increases. That opens up the AV valves, and blood begins to flow freely into the ventricle. So in this case, into the right ventricle. Last, at the end of this portion, at the end when, the ventricles by gravity, the atria by gravity have pushed most of the blood into the ventricles, towards the end, then the atria contracts. Only about 25% of the blood going into the ventricles from the atria is by atrial contraction. Most of it is by gravity. So towards the end, the atria contract and push the remaining blood into the ventricles. Now the ventricles have filled with blood, so now they need to begin their contraction, which is known as systole, and they will have to push it out into the arteries. So first, when the ventricles contract, the first thing they want to do is they want to make sure that the AV valves close so that the blood doesn't go back, so there is no regurgitation of blood back into the atria. So in order to do that, what happens is that as the blood has already filled the ventricles, the blood now pushes, actually the increased amount of blood in the ventricles, it pushes against these cusps of the AV valves, and you notice how it's pushed against the cusps, and it brings these leaflets very close to each other. At the same time, as the ventricle contracts, the papillary muscles also contract. They pull on the chordae tendineae, and the chordae tendineae will pull on the cusps. So they bring the cusps close to each other and they help to close the AV valves. So once they've done this, then the ventricle can continue to contract, and we go into the next part or the continuation of systole, where now once the valve, AV valve has closed, the ventricle's further contraction pushes the blood into the arteries. So on the right side, it will push it into the pulmonary, on the left side into the aorta. And so the semilunar valves will open because the pressure inside is more, so it kind of opens the semilunar valves. So it has pushed the blood out. Then the ventricle has to now begin to relax. So at the end of systole and at the beginning of diastole, when it's going to relax, what will happen, there is a tendency for this blood to come back into the ventricles because this valve is open. However, what happens as it tries to come back, it fills up these spaces between the valve, the cusp of the valve and the wall of the artery, which is known as the sinus. If you remember, that was called the sinus. So in both the pulmonary and aorta, it fills the sinuses, and hence these cusps look like little cushions, and so the semilunar valves are closed, and then the next cycle begins again. So this is basically the cardiac cycle, and we can look at this nice video to refresh our memory.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
So you can see in that video, it started with systole first, but I had started with diastole, but you can see the events are the same. And here, this is a good review. So if you follow this same image, and you can see venous blood first returns to the atria, the AV valves will open, the ventricles fill with blood, and once the ventricles fill with blood, the ventricles will contract, and the AV valves will close first because you want to close off the AV valves, and then further contraction of the ventricles pushes the blood through the semilunar valves, which it opens, and it goes into the arteries. So the blood enters the arteries. And then at the end of contraction, and when the ventricles begin to relax, so at the end of systole or beginning of diastole, you can see as the blood tries to come back into the ventricles, the sinuses fill and the semilunar valves close, and then the whole cycle begins again. In this case, it's showing you a breakdown of first on the right side and then the left side, whereas this is doing both together. So let's answer this question. When the ventricles fill with blood during diastole, which valves remain open? The atrioventricular valves or the semilunar valves? Very good. Yes, this is correct, because you can understand that during ventricular diastole, and when the ventricle has to fill, the blood has to come from the atrium into the ventricle. So the AV valves have to remain open. And that's why this is the correct answer. The semilunar valves will remain open when the ventricle contracts during systole, in other words. So here let's look at the numbers game. And we have a few numbers and few volumes that we will pay attention to. The first is the heart rate, which is called the resting heart rate. And the resting heart rate is normally anywhere from, we say 72 beats per minute, but it could be anywhere from, 65 to 75. That's quite normal. And you know that there is the pacemaker of the heart, which is the SA node, which sets the rhythm of the heart. But this pacemaker is under control of cardiovascular centers which are present in the medulla. Of these cardiovascular centers, there's one which accelerates the heart, or which makes the heart beat faster and more strongly. There's one which inhibits the heart, which means makes the heart beat slower. And there's a center called the vasomotor center, which causes constriction of blood vessels. So this is constriction of blood vessels. The acceleratory center is under control of the sympathetic nervous system. The cardio-inhibitory center links up with the parasympathetic nervous system. And so the sympathetic nervous system will both increase the heart rate as well as increase the contractility of the ventricles. The parasympathetic only has an effect on the heart rate, and it decreases the heart rate. Now, in us, we find that the parasympathetic system predominates over the sympathetic system at the resting level. So we have what is known as a vagal tone, which keeps the heart rate low. So that's why our heart rate is, as I said, you can take it anywhere from 65 to 75 beats per minute. It's not way over that normally. The reason being that if you want to exercise and you want to then increase the amount of blood which is going out of the heart, so you would need to increase the heart rate and increase something else which we'll see, which is known as stroke volume. So at this time, if your resting heart rate itself began at 100, imagine you would have to increase it to 150 beats per minute, which is quite a lot. So then it doesn't give the heart time to relax in between. So therefore, the parasympathetic tone is predominant, and that is known as the vagal tone, because the parasympathetic through the vagus or 10th cranial nerve is the one which sends impulses to the SA node. Now, athletes have what is known as a high vagal tone. So in them, they have a high vagal tone. In them, the parasympathetic system is more predominant, and this is good for them. So sometimes you can find a really low resting heart rate. It could be anywhere from 32 to 40 beats per minute. So it could be really low. But we'll see later how they compensate for this. So they have a low heart rate so that when they exercise or when they do their activities, then the heart rate can actually go up from 30 to 40. So it'll go up to about, could go up to 60 or a little bit more. And that would be adequate to maintain something known as cardiac output, which again, we'll see what cardiac output is. So they don't have to work really hard, or they don't need to increase their heart rate beyond 100 or 150, because if your heart rate goes up too much, the ventricles don't get time to relax in between and they won't fill with blood. So you defeat the purpose of being able to send out enough blood from the heart. So that's about the athletes. So let's look at some of these other terms. And again, if you look at this little animation here, notice that when the ventricle is filling and just before it begins to contract, so look at the volume of blood present in the ventricles just before it starts contracting or at the end of relaxation. And that is known as the end diastolic volume, or the blood which is present in the ventricles at the end of diastole. So obviously, the more the end diastolic volume, the more the ventricle will be able to push out with each beat. And the amount that the ventricle pushes out with each beat, which is known as stroke volume. So it is the blood which is pushed out with each blood per beat, which goes out of the ventricles. Obviously, if you have more to push out, the stroke volume will be more. And that's how athletes are able to maintain the amount of blood which goes out of the heart in 1 minute. So which is the cardiac output. So the cardiac output is the amount of blood pushed out by the ventricles per minute. And I'll come back to how we come back to these terms. So in athletes, just because I mentioned that earlier, I said the athletes have a low heart rate. So their heart rate is very low. But with each beat, they push out more blood. So their stroke volume is high. So this cardiac output, which we say is amount of blood which is pushed out per minute, would be the times the heart, how many times the heart beats in a minute, and times how much blood is pushed out per beat. So can you see that? So the amount of blood pushed out per beat and the times the heart beats per minute. So that's heart rate times stroke volume, which is cardiac output. So if you look here in athletes, they have a low heart rate, but they compensate by having an increased stroke volume. So the cardiac output does not suffer in these athletes. And when they exercise, the heart rate does go up, but the stroke volume also increases considerably in athletes, and that's how they are able to maintain the cardiac output to, where oxygen is reaching their tissues. Let's look at another term that we have here, which is called end systolic volume. So again, watch this animation. So after the heart has pushed out the blood, notice in the ventricles the amount of blood which is left, which is this residual volume, or called end systolic volume. And the name itself is explanatory, which is the volume present at the end of systole. So that's the end systolic volume. So we can see that end diastolic volume, which is the amount of blood at the end of diastole or just at the beginning of systole. If you subtract the stroke volume from that, you get end systolic volume. So what you have to begin with, what you push out, gets you what remains inside the ventricle at the end of systole, which is the end systolic volume. Now let's see how we can increase cardiac output. So we must remember these parameters. Cardiac output is stroke volume. So cardiac output is stroke volume times heart rate. So if you increase either one or you increase both, you can increase cardiac output. And we saw in athletes, while this is low, they increase their stroke volume. So that's how they are able to maintain it. Now let's see what are the ways that we can increase stroke volume. The first is that if we have an increased end diastolic volume, so if the ventricles were filled with blood, they'd be able to push out more. So you increase your end diastolic volume, you automatically will be able to increase stroke volume. What are some of the ways that you can increase end diastolic volume? One way is to increase the venous return to the heart. So we remember that this is the heart here. So, and this is the AV valve. So this is the right side, right atrium, right ventricle. Okay, left atrium, left ventricle. So if you bring more blood back into the atria, automatically more will go into the ventricles and then it can go out. How would you increase venous return? The way you can increase venous return, one way to increase venous return is exercise. Because the veins from the lower limbs are dependent on skeletal muscle activity to push the blood up, because these veins are going against gravity. So if you exercise, the skeletal muscles contract, they squeeze the veins and they increase the blood going through, which will finally drain into the inferior vena cava and it will go into the right atrium. So you will end up with a greater amount of blood in the ventricles finally, which is increasing end diastolic volume. So exercise is one very important factor which increases end diastolic volume. Another factor which increases end diastolic volume is the length of diastole. For example, if you in athletes where they have a low heart rate or the heart rate is less, you can see the ventricle gets enough time to relax in between the heartbeats. So when it has enough time, the ventricles will fill better. So increased length of diastole leads to increased ventricular filling. Another thing, if you make the ventricles contract better, that means the contraction of the ventricle is really strong, that also will increase stroke volume. And this is, if you remember from ANP1, do you remember the cross bridges which are formed between actin and myosin? So if the muscle is stretched, then it is able to contract better because you have more cross bridges that can form. Now, this is especially true of cardiac muscles and fibers, and this is known as the Frank-Starling law, where stretching the cardiac muscle fibers helps to make them contract better. And you can understand that if there's increased end diastolic volume, so again, if we draw this heart like this, so if this ventricle were dilated this way, so there's more blood inside the ventricle, the muscle will be stretched. When it is stretched, it will be able to contract better. So increased venous return leading to end diastolic volume will also help in making the ventricle contract better. Another factor which helps to increase stroke volume is the sympathetic stimulation. The sympathetic nervous system, irrespective of the stretching of muscle fibers, it has a positive action on the cardiac muscle fibers itself. So it makes the cardiac muscle contract better and more efficiently and more strongly. The parasympathetic nervous system has no effect on cardiac contractility because the ventricles have very few parasympathetic receptors there. The sympathetic system, however, does. So the sympathetic stimulation, anytime there's sympathetic stimulation, it will make the cardiac muscle contract more strongly. If it contracts more strongly, it's able to squeeze the ventricle better, and automatically the stroke volume will increase. Then we have certain hormones and ions. So epinephrine and norepinephrine are important, and they help again. They act very much like the sympathetic nervous system. And calcium ions are also important in helping to make the contraction of the heart better. Another factor which helps in stroke volume is the resistance in the arteries. So again, if we look at the heart like this, so here's the pulmonary artery coming out from here and the aorta coming off from the left ventricle. So this is left ventricle, this is right ventricle. The resistance in the arteries, in other words, the arteries should not offer too much resistance. Blood should be able to flow easily from the ventricles into the arteries. If that condition is normal, then the stroke volume automatically will be adequate, and you can increase your stroke volume adequately in such situations. If, on the other hand, if the resistance offered by the arteries is not normal, let's say there was a atheromatous plaque or cholesterol plaque here, can you understand that here now the pulmonary artery is narrowed, so any blood flowing from the ventricle here at this point is going to find resistance. It's going to find something that it has to push against. So your stroke volume automatically will not be as much as it would be in normal circumstances. So the resistance in the arteries also needs to be normal, and it should not be high in order for the heart to be able to push out an adequate amount of blood per beat. The other factor which we can see which increases cardiac output is, so we saw heart rate times stroke volume, so we already took care of stroke volume. So if you increase the heart rate, that too will increase cardiac output, and an increase in heart rate of over 100 beats per minute is known as tachycardia. One factor which increases heart rate is sympathetic stimulation. So, and the sympathetic stimulation occurs during times of exercise. So when you exercise, not only do you increase venous return here, you also stimulate the sympathetic nervous system, which happens to increase the heart rate. And you can see it also increases the contractility. So you can see how exercise has a very, very positive effect on cardiac output. And it stands to reason, because when you're exercising, your tissues need more oxygen, they need more blood. So automatically a heart wants to pump more blood out per minute. So when it pumps, and how it can do that is by increasing stroke volume and heart rate. Stress. Again, stress is a condition which increases heart rate. In stressful situations, the sympathetic nervous system is stimulated, and you all know of how your heart is pounding whenever you're in a stressful, if you're frightened or see something gory. So stress does that, as well as in times of stress, another hormone called cortisol is produced, and that makes the receptors more sensitive to epinephrine and norepinephrine, and that too helps, that too raises the heart rate. And then we have certain receptors present in the atria and in the walls of the atria, and these are known as baroreceptors, and these are pressure receptors. So what happens is that whenever the pressure inside the atria is more than normal, for example, if you have an increased venous return in the atria, so automatically if there's an increased venous return, the atrial chamber will fill. So let's say this is the right atrium and right ventricle, left and atrium and left ventricle. So if there's more blood getting into the atria, the atrial walls will dilate, so the pressure inside the atria will be more, and it stimulates these baroreceptors, which automatically go and stimulate the sympathetic nervous system. So when they stimulate the sympathetic nervous system, they help to increase the heart rate, and also they help to increase the contractility of the heart, which is a function of the sympathetic nervous system. So that's another feature which helps to increase the heart rate. Then we have conditions where the heart rate may be very, very high, more than, way more than 150 beats per minute. And such a condition is known as ventricular fibrillation, where the heart really beats or very, very fast. It actually quivers. It doesn't even beat. In such situations, when the heart rate is very, very high, then actually your cardiac output decreases, because when the heart rate is really high, the ventricles are not able to relax. So relaxation is not possible because the heart is beating so fast. And when it's not able to relax, then automatically its end diastolic volume falls and its stroke volume falls. So on one hand, you're increasing heart rate a lot, but on the other hand, you decrease stroke volume so much, and so the heart really becomes ineffective, and that's seen in ventricular fibrillation, and I'll show you the video. And then we have hormones and ions. The hormone is thyroid hormone, which increases the basal metabolic rate. So it helps to increase the heart rate, and it also makes the receptors more sensitive to the effects of epinephrine and norepinephrine. And then we have ions. Calcium again would increase the heart rate, as well as calcium helps to increase the contractility of the ventricle. So let's look at this situation of ventricular fibrillation.
The heart usually beats about 60 to 100 beats per minute. With each beat, your heart pushes blood throughout your body. The upper chambers, the atria, contract at the same time. Then the lower chambers, the ventricles, contract at the same time. Ventricular fibrillation often starts with a fast rhythm in the lower chambers of your heart, called ventricular tachycardia. It is caused by a problem in your heart's electrical system. Ventricular fibrillation is a very fast rhythm in which your heart beats 200 to 300 times per minute. When your heart beats this fast, it is merely quivering rather than actually beating. Less blood and oxygen is pumped to your body and, most importantly, to your brain. Ventricular fibrillation is the most dangerous arrhythmia because it often leads to sudden cardiac arrest and sudden cardiac death.
Now let's look at factors which decrease cardiac output. So automatically it'll be all of the opposite what happened when we increased it. So anything which decreases stroke volume or anything which decreases heart rate. So if you decrease venous return, for example, you're sitting for a very, very long time, your blood pools in the veins in the lower limb. So there's pooling of blood in the veins of the lower limb. And so the venous return is decreased, which means the ventricles don't get enough blood, and blood can't go out. Stroke volume decreases. So that's automatic. If there's decreased ventricular filling, which happens when your heart rate is really high, so the ventricles do not get time to relax, automatically they fill with less blood, end diastolic volume is low, and your stroke volume will be low. Another condition is raised intrapericardial pressure. So you all know that here's the heart, and this is surrounded by the fibrous pericardium. So here's the fibrous pericardium, and lying on the inner aspect of the fibrous pericardium is the serous pericardium. So this is the parietal layer, and here is the visceral layer. So normally this space this pericardial cavity, which is here, is a very narrow space filled with pericardial fluid. Suppose the pericardial space was filled with a lot more fluid than normal, or filled with blood. So let's say the space became this big. So now what happens is your heart actually has less space in which it can dilate or contract, so the filling will be affected. So this is all that the heart is able to fill or push, and because this fibrous pericardium on the outside is very thick and unyielding, so it doesn't stretch. So with the result, any raised pressure here is going to make the heart sort of get smaller and smaller. It won't let it fill properly. If it doesn't fill, automatically stroke volume is decreased and your cardiac output will decrease. So raised intrapericardial pressure also decreases stroke volume. Another thing is that, remember I mentioned earlier, if, for example, the resistance in these blood vessels which are exiting the ventricles, if that is increased, for example, you have high blood pressure due to a cholesterol plaque, so there again, then the heart has to contract with much greater force in order to push the same volume of blood out. And if this is really narrowed, the heart may not be able to do that, and automatically a stroke volume decreases. Another feature which would decrease stroke volume is if the heart's contractility is decreased. So let's say a portion of the heart was damaged, such as in myocardial infarction. So then that part of the heart tissue is no longer able to contract, and automatically your contractility is decreased and your stroke volume will decrease. Here let's look at causes of decrease in heart rate. A decrease in heart rate of less than 60 beats per minute is known as bradycardia. So if there's raised parasympathetic stimulation, and then your heart rate could be decreased. This can happen physiologically in some people, who meditate, some Buddhist monks and otherwise people who meditate are known to have very, very low heart rates, and they seem to be able to control their autonomic nervous system in ways that we are not able to understand. So their heart rate is really low, and that's because of a very high parasympathetic stimulation. Certain ions like sodium and potassium also affect the heart rate. They bring it down, as does cold temperature. Heat, on the other hand, hot temperatures actually raise your heart rate, and you've all seen if you have fever, your heart rate goes up because high temperatures increase the metabolism and automatically the heart rate goes up. And then athletes already mentioned that they have a physiologically low heart rate because of that high vagal tone, and they compensate by having a greater stroke volume. Now we have something known as congestive heart failure. So if you look at the chambers of the heart, and this is something important that you should know. So if you look at this, and here's the pulmonary artery and here's the aorta. So if any part of the output, any part of this cardiac cycle or any valve is stenosed or narrowed, or it's not closing properly, the cardiac cycle would be affected, and automatically the blood would tend to backtrack into areas from where it came. So just to give you one example, so on the right side, if for example this tricuspid valve was narrowed, so blood is not able to go from right atrium into the right ventricle. It doesn't empty completely. If it doesn't empty completely, it backtracks into the superior vena cava. It'll backtrack into the inferior vena cava. These superior vena cava is bringing blood from the head and neck region. So you find that neck veins get engorged. And in the inferior vena cava, it's bringing blood from the lower limb and the pelvis area. So you will find that the veins in the lower limb are dilated and engorged, and that leads to fluid being pushed out into the surrounding tissue, and it causes what is known as pedal edema, or the foot is swollen. And then inferior vena cava also has, if you remember, the veins of the liver, hepatic veins drain into inferior vena cava. So blood backtracks into them too. So the liver and other abdominal organs may be tender. So all of this you can see is to do with something on the right side. So this is called right-sided heart failure, right-sided congestive failure. On the left side, if this was to happen, so imagine if the mitral valve was narrowed. So if you know the cardiac cycle, it becomes easy to understand what will happen. So blood will not go from left atrium into left ventricle. It will backtrack into the pulmonary veins, which are bringing blood from the lungs. So the blood from the lungs is not able to empty out properly. So there is congestion in the lungs. So left-sided failure causes congestion in the lungs. And usually these people have breathing problems, because if the lungs are congested, then the gas exchange is not able to occur properly. So knowing the cardiac cycle helps you to, answer questions like this, just based on where blood is going from which chamber to which chamber, and then how does it exit the heart. So let's look at this question and see. Cardiac output is heart rate times stroke volume. So which statement here is incorrect? Excellent, yes. I'm sorry. You guys got it wrong. The correct answer here actually is, and I'm going to re-poll it again, so I want you all to think over this. You didn't read it properly. A low heart rate as an athlete allows the stroke volume to be higher to maintain cardiac output. This is true. I'm asking you which statement is incorrect. So look at it carefully. Yes, exercise will decrease stroke volume and cardiac output. This is an incorrect statement. Exercise, on the other hand, increases stroke volume because there's an increase in venous return, which increases in diastolic volume. So cardiac output increases in exercise. And, so that's just, think of it as common sense. So this is not a true statement. So this is incorrect. This is correct. In heart rate in athletes is low, but the stroke volume is high, and that's how you maintain cardiac output. Very high heart rate will obviously not allow the ventricles to relax, so stroke volume automatically gets decreases. And if you increase the contractility of the chamber, the weight, the strength of the contraction, and you reduce resistance in the arteries, this is what you want, your stroke volume automatically goes up. So all the other statements are true, and this is the untrue statement. Now this shows you an electrocardiogram, and the method of taking this is known as electrocardiography, and this measures the electrical activity of the heart, where here there are waves which you see, this is known as the P wave, this is called the QRS complex, and then this is called the T wave, and each one signifies something happening some electrical activity happening in the cardiac tissue. So P wave is atrial depolarization. The QRS complex is ventricular depolarization, which follows atrial depolarization. And then the ventricle repolarizes. So T wave is ventricular repolarization. And here this just shows you a normal electrocardiogram, and this shows you an abnormal one. You can see the spacing between them. You can also see these high T waves. So this, you can just differentiate between these two. You don't need to really go into great details about them. So here let's look at heart sounds. And the first heart sound, the lub-dub sound that you hear when the heart is beating. So in the first heart sound is due to closure of the AV valves. And the second heart sound is due to closure of the aortic and pulmonary valves. And let's see if we can hear these heart sounds. So that was a little faint, but I think you could still hear it. And let me show you somewhere where there's a stenosis. So you got some idea, though it's a little faint. Now, the first heart sound is due to closure of AV valves and second is due to closure of aortic and pulmonary. So let's answer this question. When would you hear the first heart sound? At the beginning of systole, at the end of systole, the beginning of diastole, or end of diastole? Good job. Yes, the first heart sound is heard at the beginning of systole. Remember, it's the closure of the AV valves. When do you want the AV valves to close? When the ventricle begins to contract, you want those valves to close so that blood doesn't go back into the atria and those leaflets are not blown back into the atria. So at the beginning of systole. And at the end of systole, or just at the beginning of diastole, is where the second heart sound would be heard. Now here's another question, and I showed you that congestive heart failure. What would be the physiological result if the mitral valve was stenosed? So think of the cardiac cycle and think what would happen. Excellent. Yes, on the mitral valve, which is present on the left side. So if that was stenosed, it would back up in the left atrium. It can't go from left atrium into the left ventricle. All of it cannot pass through. So it will back up in the left atrium, in the pulmonary veins, pulmonary in the lungs, and there'll be congestion there. So this is the right answer. This would be if there was a tricuspid valve stenosis. Now let's look at pulse and blood pressure. So pulse is just the palpable wave that you feel in the arteries, and there are various arteries which you use to feel someone's pulse. The radial artery, you use the superficial temporal, you can feel the peripheral pulses in the dorsalis pedis, femoral, all of these. And blood flow is the amount of blood that passes out in a minute, and it's always from an area of high to low pressure. That's why from the aorta it passes in the arteries, it's going down, because aorta at the beginning is the highest pressure, and as it keeps going down the pressure decreases, so always from high to low pressure. So what is this pressure or blood pressure? Now blood pressure has two terms to it. One is called systolic pressure and one is called diastolic pressure. So blood pressure is the amount of blood that is passing through a blood vessel and the resistance which is offered by that blood vessel. So which is this? So blood pressure is cardiac output times peripheral resistance. Now in the larger arteries, the resistance offered is much less. So it's usually in the smaller arteries that the resistance offered is more. So it is in the arterioles that we are really concerned about, where peripheral resistance is what will have an effect on blood pressure. So here, if you look at this, let's say this is a large blood vessel and blood is flowing through it, the blood in the center flows through easily. But the blood on the periphery, the one that is in contact with the walls of the blood vessel, that's where the resistance is offered. So in large blood vessels, since most of the blood is in the center, the resistance doesn't matter. But when you have a small blood vessel like this, you can understand that most of the blood is in contact with the walls, and these are the arterioles. So that's where the peripheral resistance is important. And if it rises, then the blood pressure will automatically rise. Now, in blood pressure, there are two terms we use. One is called systolic, which is when the ventricle contracts and pushes blood out. So the pressure in the arteries at that time is systolic. And when the arteries relax, then because of recoil, they relax and they push the blood further, and the pressure inside that segment of the artery which has relaxed is less, and that's known as diastolic blood pressure. And pulse pressure is systolic minus diastolic blood pressure. So usually we like to make sure that a person's blood pressure is close to 120 by 80 millimeters of mercury or slightly less than that. There are some people whose normal blood pressure itself may be low. It may be 90 over 60. And that's just normal for them. Now, let's look at cardiac output we've already discussed. Let's look at what what is important, what determines peripheral resistance? First is what is known as viscosity of blood, or to put it, something like thickness of blood. And the example I like to give is if you compare honey and water, we say honey is more viscous as compared to water, because water is very thin, watery, and honey is a little thicker. So if it was flowing through a tube, it would flow more slowly, because offering more resistance. So here this shows you, so this is in a blood vessel. So you can see, if you can see more cells here, it's highly viscous. And when you have fewer cells, the viscosity is less. The second is the lumen diameter. Automatically, if the lumen is narrow, as in vasoconstriction, this automatically leads to an increased resistance. If the lumen is wider, the resistance is decreased. So vasodilation decreases peripheral resistance, vasoconstriction increases peripheral resistance. And lastly, we have vessel length. The longer the vessel, greater is the peripheral resistance. So longer vessels have greater peripheral resistance. And let's just look at lumen diameter and how it would affect blood pressure.
Atherosclerosis is the buildup of fatty plaque on the inside of the arteries. This buildup narrows the artery and impedes or blocks blood flow. Ultrasound imaging shows the blood flow in the arteries. Get screened and share this video with a friend. Visit Lifeline Screen.
So you can see in that when the vessel is narrowed, then blood has to flow through that narrow passage, and so resistance is offered, and automatically the peripheral resistance will go up, which means the blood pressure will go up. So let's answer this question. Would blood doping increase peripheral resistance? Yes, very good. Yes, because in blood doping, it is a situation where a person transfuses blood that they have donated a while ago. They transfuse it into themselves without having lost any blood. So they actually have physiological polycythemia. So your blood has more cells than normal, making it really thick, and that causes an increase in peripheral resistance. How about this one? Good job. Yes. Anemia will decrease peripheral resistance because you have fewer red blood cells in anemias. And usually it is if the red blood cell count is low. If just the hemoglobin count is low, then that will have no effect on the peripheral resistance, because anemia could be low hemoglobin or low red cell count. And this question, the sympathetic nervous system causes vasoconstriction through that vasomotor center, which has only connections with the sympathetic nervous system. So what will be the result on peripheral resistance? Okay, for some reason yes. Very good. Excellent. Yes, it will increase it because vasoconstriction means the vessel is becoming more narrow. So most of the blood now is in contact with the vessel wall, and that increases peripheral resistance. And in fact, it's good for us because in situations where, let's say, someone is dehydrated or someone is bleeding severely, so you have hemorrhage, then automatically there is blood loss or fluid loss. There is a tendency for cardiac output to fall and blood pressure will fall. But the body wants to maintain homeostasis. So what it does is the body goes into this stress response and the sympathetic nervous system becomes activated. It causes vasoconstriction, which increases the peripheral resistance, and therefore it maintains the blood pressure for some time. So your blood pressure increases and it maintains it for some time till, of course, you have to replenish the fluid loss or the blood loss. I mean, till such time it cannot go on endlessly, but at least in the beginning, homeostasis is maintained by this sympathetic response. Let's look at regulation of blood pressure. So the first one is anything that regulates cardiac output automatically regulates blood pressure, because blood pressure is dependent on cardiac output and peripheral resistance. So all of that we've done with cardiac output would apply here. Let's look at peripheral resistance, and let's see how peripheral resistance is controlled. So there are some short-term controls, and this is under the nervous system. So under the nervous system, these short-term controls are called neural controls, and they are through what are known as baroreceptors, and these are present in the carotid sinus and aortic arch. And these, whenever the blood pressure is low, so if the blood pressure is low, at that time what these baroreceptors do is they sense this low blood pressure, so they send responses to the cardiovascular centers in the medulla. And what they'll do at this time is that if the blood pressure is low, they will cause a stimulation of the sympathetic nervous system, because you want the blood pressure to come back and be high. You want it to bring it back to normal levels. So they will cause stimulation. They'll act on the cardioacceleratory center. So they'll act on that center. They'll also act on the vasomotor center. By doing this, they cause sympathetic stimulation, which will increase your heart rate. It will increase your contractility, so your cardiac output goes up. By acting on the vasomotor center, they cause vasoconstriction, and therefore they'll increase your resistance, your peripheral resistance, and your blood pressure goes up. On the other hand, if your blood pressure has become high for some reason, let's say you have a lot more fluid in your body, then what they do is they inhibit the cardioacceleratory center. So they inhibit the sympathetic center and they stimulate the parasympathetic center. So here your heart rate comes down, the vasomotor tone goes away, so there is dilation of the blood vessels, so resistance falls and your blood pressure comes down to normal. So that's how these neural controls through the baroreceptors happens. The other thing that the neural nervous system does is it also causes distribution of blood. So blood goes to whichever area it's needed. And one very good example you can see is that after you've eaten a meal, you will find that, especially in winter, you begin to feel cold and you also begin to feel a little drowsy. And this is because less blood goes to the skin. There's vasoconstriction there, which makes you feel cold. Less blood is going to the brain, adequate, but not more than normal. And then most of the blood is shunted or distributed to the gastrointestinal system so that digestion can occur. However, if while you're digesting your food, somebody tells you there's a fire close by and you need to run, automatically the sympathetic system will come into play and blood will now be redistributed. So from the gastrointestinal tract, it will actually go to your skeletal muscles, to your brain, to your heart, so that all of these areas can work well and you can take care of the problem. So you can see how blood is distributed based on needs. The other is the lumen diameter, which I just mentioned. So this is based on all blood vessels have a normal vasomotor tone, so they're slightly constricted. So when blood vessels need to be constricted, the sympathetic system gets activated, like the example I just gave you earlier. And when they don't need to be stimulated, the sympathetic system is inhibited, so the blood vessels automatically dilate at that point. So the lumen diameter, if it constricts, your peripheral resistance goes up. If it dilates, the peripheral resistance goes down. So let's look at this video on neural controls.
Nice ride.
Nice try.
Arterial blood pressure determines how much blood flows into the capillaries, where the exchange of nutrients and wastes between blood and body cells occurs. If the pressure is too low, not enough blood goes into the capillaries. If the pressure is too high, blood vessels can break, causing internal bleeding and possibly strokes. The aortic arch and common carotids are arteries that supply blood to critical areas of the body. The aortic arch supplies the body, and the common carotids supply the head. Within these major arteries are structures called baroreceptors that measure blood pressure and send nerve impulses up to the brain. If pressure is high, the walls stretch. If pressure falls, the walls are less stretched. Baroreceptors send information to the cardiovascular center in the medulla oblongata in the brain. When blood pressure drops, the slower rate of impulses from the baroreceptor conveys this disruption to homeostasis to the CV center. The CV center sends its own nerve impulses out to the heart and many of the blood vessels. The heart starts to beat faster, sending blood to the arteries at a faster rate. It also beats with greater strength, sending greater amounts of blood to the arteries with each beat. The nervous signals from the brain also signal secretion of hormones that constrict blood vessels, increasing their resistance. As the pressure of the blood in the arteries goes up, the change is detected by the baroreceptors that send the information about the restored blood pressure up to the brain. When the brain receives this response, it will cut back on its stimulation to the heart and blood vessels because homeostasis has now been achieved.
Now let's look at chemical controls. These controls are more important in the respiratory system and to control respiration, but increased carbon dioxide or decreased oxygen, this stimulates the sympathetic nervous system, and it causes cardiac output to rise. Other things which affect peripheral resistance are certain hormones. These hormones, ADH stands for antidiuretic hormone. It's also known as vasopressin. As the name suggests, vaso is blood vessel, pressin means pressor or tenses it, so it causes constriction. Epinephrine, of course, is a hormone which causes vasoconstriction. And angiotensin, again, as the name suggests, angio is blood vessel and tensin is tensor or constriction. So these three hormones, they cause vasoconstriction and they will increase peripheral resistance. Opposing them is this hormone which is produced by the atrial walls called atrial natriuretic peptide. And atrial natriuretic peptide, this decreases blood pressure, and how it does that is it causes excretion of sodium, and with sodium excretion of water. So when fluid is removed from the body, automatically blood volume falls and blood pressure drops. So that's how this hormone does. So these three cause increase in resistance. This one decreases and causes decrease in blood pressure. Then we have certain inflammatory products and alcohol. They cause vasodilation and automatically they decrease peripheral resistance and blood pressure. Now this was all short-term control. When we look at long-term control, the kidneys have a big role to play, and they do it by excreting fluid. So the more fluid you have in the body, the more it is excreted, because if you have increased fluid in the body, that increased fluid, that means there is an increased blood volume, and this automatically means increased blood pressure, because increased blood volume would lead to increased cardiac output, so that will automatically mean increased blood pressure. So if you remove the fluid, you automatically will be decreasing blood pressure. And then we have an indirect mechanism through this thing called renin-angiotensin, and you already saw angiotensin here. So this happens in the kidneys. So in an arteriole present in the kidney, when the blood pressure is low, the smooth muscle cells of the arteriole, they sense this and they secrete something known as renin. So low blood pressure causes renin to be secreted. Renin goes and acts on angiotensin, and angiotensin then causes production of a hormone called aldosterone, and this is from the adrenal gland. Aldosterone acts exactly opposite to ANP. What it does is it causes reabsorption of sodium and hence water. So when it does that, it will increase your blood volume, which automatically will increase your blood pressure. So that's the indirect mechanism. If your blood pressure is high, then the renin-angiotensin mechanism doesn't work, and the body will actually, then ANP will be produced and sodium and water will be pushed out of the body. Hypotension is a term where the blood pressure is less than 100, the systolic blood pressure, and this could be normal. There are some people who have a normal blood pressure of 90/60, and that's normal for them. So hypotension is not really, someone doesn't suffer from a disease. You can have a hypotension at a particular time. For example, if you lose a lot of fluid or you lose a lot of blood and your blood pressure falls, then that is dangerous, and that at that time actually we call it, that's typically when it's called hypotension. So low blood pressure, but again, low blood pressure is not a disease like high blood pressure. It only occurs for a particular span of period. You do not suffer from it for a long period of time. Hypertension is when the blood pressure is more than 140/90, though nowadays even 130 millimeters of mercury systolic is considered high, or at least one is worried about it. So, you want to keep your blood pressure below 120/80. So let's see the two types of hypertension we have. Primary hypertension is present in most people. In 90% of the people, it's primary hypertension. And no real cause is known, but they think some of these are the probable causes. So it could be inherited. Maybe somebody in the family has it, and so it's passed down. Some races are more prone to hypertension than others. Diet is a big factor. So, eating fatty foods, a lot of cholesterol, that causes deposition of cholesterol plaques, which cause atheromas, and they raise the peripheral resistance and can increase blood pressure. Obesity also. Age, the older you get, these arteries become less elastic. You begin to suffer from something known as arteriosclerosis. And less elasticity means the arteries cannot expand, and then that can cause resistance. And again, atheroma is also more common with higher age groups, and hypertension. Diabetes affects blood vessels all over the body, and that also can lead to hypertension. Smoking, nicotine by itself is a powerful vasoconstrictor, so that raises resistance, and plus vasoconstrictor, and plus smoking also increases cholesterol levels. Stress, because stress releases hormones like cortisol and epinephrine, norepinephrine, which are vasoconstrictors, so that could cause. So any of these could be causes which have led to primary hypertension, but the exact cause is difficult to pinpoint. Secondary hypertension is due to anything in the kidneys, or there could be endocrine disorders, there could be something else, there could be a definite cause for it, and secondary hypertension is seen in about 10% of cases. So let's look at hypertension.
Hey, Darcy, look. 100,000 miles.
So?
Blood pressure is blood flow.
the volume of blood pumped out of the heart per beat multiplied by arteriolar resistance to the blood flow. Blood flow depends on the rate of heartbeats and the volume of blood pumped out with each beat. If rate or volume increases, blood pressure goes up. Likewise, increased resistance raises blood pressure as when arteries downstream from the heart constrict. Over time, high blood pressure or hypertension damages many organs. First, the heart works harder to pump out more blood, or against higher resistance. The heart then requires more oxygen and is more susceptible to angina or a heart attack. Second, arteries and arterioles can be damaged. Arteriosclerosis results when blood moves through arteries and arterioles at high pressure, damaging the vessel. White blood cells are drawn to the damaged area to form plaque. Third, kidneys can be damaged. The capillaries of the kidney are delicate. Continually subjected to high blood pressure, they break down, becoming permeable to proteins and other molecules. The kidney's tubules can become clogged, decreasing the kidney's ability to make urine. Also, the proteins injure the capillaries' membranes, causing more damage and worsening the situation. Fourth, the retina of the eye can be damaged if its delicate capillaries are damaged. Localized hemorrhages can occur, causing scarring and formation of new imperfect capillaries to replace the old ones. Finally, the blood vessels of the brain can be injured. High blood pressure can cause clots to break off from atherosclerotic plaques, blocking blood flow to the rest of the brain. This is called a thrombotic stroke. Continual exposure to high blood pressure may also cause a blood vessel to burst, leading to a hemorrhagic stroke.
So you can see how, high blood pressure affects almost every organ of the body. So it's important to keep your blood pressure within normal range. And this is a very good slide which shows you, like I talked about, the neural control, the baroreceptor. So you can see if your blood pressure is high, if it goes above normal, the baroreceptors at this point, they are stimulated. What they do is they inhibit the cardioacceleratory center and the vasomotor center, but stimulate the inhibitory center so that there is relaxation or vasodilation of the blood vessels. Sympathetic impulses are decreased, heart rate, contractility decreases, cardiac output decreases, so your blood pressure comes to normal. If on the other hand your blood pressure is low, so you want to bring it back up, so then they stimulate the acceleratory center. Heart rate goes up due to sympathetic stimulation, contractility and cardiac output goes up, blood vessels constrict, so vasoconstriction, and it comes back to normal. So let's look at this question. Which of the following would be a way the kidneys control blood pressure? So increased blood volume would cause increased filtration and increased urine formation, or increased blood volume would cause decreased filtration and decreased urine formation. Good job. Yes, if you have increased blood volume, you want to get rid of it. So you push it out through urine. So you increase your filtration, and that's how the kidneys help directly, and they cause an increased urine formation. And this is the reason why we want to give people diuretics with high blood pressure. So you want to get rid of fluid volume. So that wraps up this presentation.